that's the whole point, is we want something that's going to move with the clinical picture that we can hang our hat on to say, did I do what I'm trying to do?
Welcome to the DUTCH podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at DUTCH. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, and welcome to this week's episode of the DUTCH podcast. Now, today's a little bit of a special day because we have two guests on the show. I've got Mark Newman, founder of the DUTCH test, and I've got Dr. Mark Holthouse, MD, who has been practicing in men's health and is really thought of as one of our premier testosterone experts. We're going to have a dialogue about the recent publication that we had just put out in Frontiers in Reproductive Health. It's titled Alternatives to Serum Testing for Transdermal Testosterone Monitoring, a review of clinical data and correlation with clinical response. You can find a link to our open access paper in the show notes if you want to pull that open. And there's also a link there to the blog that we wrote that summarizes it because it is a very meaty review. Now, essentially with this review, what we did was we wanted to see what evidence is out there in regards to monitoring testosterone replacement therapy using different techniques and media. So we look at serum, we look at saliva, we looked a little bit at dried blood spot and a little bit at urine. And what we really found and what we published in this review is that the predominance of evidence really is for serum only. And in fact, one of the reasons why we wanted to talk about this with saliva in particular is that it's used regularly to monitor. Saliva is used to monitor testosterone. And a lot of providers have done that for so long. We wanted to see what the data said about that. And in the end, we could not find any papers that showed correlation with clinical symptoms. And that was actually a surprise to us as well, because we thought there would be some body of research that we would be comparing it to. So ultimately, this is an open invitation for dialogue, and we really wanted to hear how this plays out in Dr. Holthouse's practice because he's doing so much testosterone replacement therapy. And ultimately, this paper was kind of a tough one to publish because we didn't want it to offend anyone who's been using salivary practices. I mean, we haven't published the serum and the saliva research, but we felt it was really necessary and part of the process of challenging what we think we know and advancing science in integrative medicine to have an honest conversation about where we're at today with the evidence. So let's go ahead and dive in. I want to first introduce Dr. Mark Holthouse. As I mentioned, he's a medical doctor and he's practiced family and functional medicine for over 3 decades, specializing in men's and women's hormones and peptides and longevity medicine. He was one of the first cohort to receive IFM certification in functional medicine, and he's taught the men's hormone advanced module for 14 years. He's also served as a faculty member at Loma Linda University School of Medicine, where he taught preventive cardiology. His integrative approach combines peptide therapy, lifestyle foundations, hormone optimization, and cardiometabolic health into a comprehensive longevity program. He currently sees clients full-time and serves as the Chief Medical Officer at the Functional Medicine Institute. And outside of his clinical role, he continues to teach and educate colleagues and patients alike. We are lucky to have him. Let's go ahead and get started. Thanks for joining me. We're going to try our best to keep the two of you straight in the podcast for people who are just listening today. Mark Newman, for providers who are newer to the testosterone monitoring debate that we're going to be talking about today, can you briefly describe what is the core disagreement that we see clinically? And we see these people that are using kind of different approaches in the integrative medicine world. Why do you think it's become contentious? And why did we have to do this formal review?
Yeah, it's such a big
I know it's a big question, but I think it's important to start here because I know
Yeah.
I understand your intent with this, and we want to
Yeah.
make sure we start there.
I think it's easier for me to start with where there's agreement. So
Mhm.
what you can show in the literature is if Dr. Holthouse takes a guy and gives him a testosterone injection, and then he's really good friends with lots of lab people, so he gets lots of free testing, and he monitors blood and urine and saliva over time. What the literature shows is those track pretty well. Like they tell a similar story. So then we can have this interesting debate about, serum versus urine and what it has to offer, and then versus saliva and how that might track a little bit better with free testosterone. But you can get a pretty decent window of free testosterone from serum, and you can have that conversation, but they dance together with each other. And so it's a different conversation. So then as soon as you take a hormone cream or gel and you put that on a patient, now we have this like pretty wild discrepancy where you have 50 milligrams is always the place I send people. At 50 milligrams, the serum in the urine, if you take a guy at, say, a serum of 300 or 290 or something, you say, hey, that's not getting the job done for him. And then, of course, there's free testosterone. But if you're in that neck of the woods and you use 50 milligrams, generally they're going to jump up to, and totally jump in here, correct me if I'm wrong, Mark, probably 450, 500, maybe you get them to 600 with 50 milligrams, maybe not, whatever, but it's a modest increase. And you see an analogous change in most people in urine. And then the saliva at that point depends on when you test, but generally speaking, they're in a whole other stratosphere. Like you're sending let me put it this way. If you match that saliva number with an injection, you'd be giving them an injection about 10 times higher than you wanted, and you would never do that. So then we all pause and we say, holy cow, this is really, really different. Like, which one makes sense? And so the history of how we got here is a long story, and it might be worth telling to give some context to this. But that is the discrepancy, is the increase. This is not controversial. The increase in serum and urine compared to saliva is vastly different when it's a cream or a gel put on the skin. And we all have been sorting through that since the early 2000s. There's been lots of confusion over that. And so, for me, I was trained in the world of saliva testing and taught that, hey, these big numbers, they're the ones that matter, and we need to titrate to those numbers. And as I dug into the data, I realized, the clinical data tells a very different story and is in more alignment, particularly for testosterone and estradiol, with what's going on in blood or urine, although there are some caveats to that as well. And so just to give more of a short answer, that's the issue, is that wild discrepancy. Which one tells a better clinical story is something I've been digging into, and really digging into for the last 15, 20 years. And it's a fascinating story, but it changes people's habits of how they treat patients fairly dramatically. So it's important that we know what's true and what's not true and what's still unknown, and we are pursuing, truth and best practices together. And that's, the reason for this conversation, and I think it's a really important one.
Yeah, one thing that I've heard you say, what has stuck with me, you'll be glad to know your words stick with me for sure, is that research sometimes can't prove what's right, but it can certainly prove what's not right. And I think that sentiment is really an interesting one, that usually we get to truth in physiology and medical practice by one by one kind of filtering off hypotheses that we can't bear out in clinical research. So I do think it's worthwhile for you to share a little bit about that background that you have, starting in saliva, and because it's the inception of the DUTCH test really comes from that, number one. So if you use a DUTCH test today, it's just an interesting story about how the company was founded and where it came from. But the other thing that I think is really important from my point of view is that I liked learning about you, that you believed one thing and then you kept looking at data, and then it changed your understanding, and now you believe something different. Because I think that is what science is. And I think in our industry, sometimes with clinicians, we train under someone, and it's almost like a guru type environment, and it becomes dogma. And my caution as a clinician for all clinicians listening is we don't act on dogma. Dogma doesn't work in medicine. We have to apply science and evolution. And I just think the story of that would be interesting for you to share if you're open to it.
Yeah. And there really are two different channels of that story. The DUTCH test at its heart was about taking hormones, taking the measurement of hormones and adding the measurement of metabolites and opening up that picture and moving it from kind of a two-dimensional story to a three-dimensional story. And that's centered really around a non-HRT scenario of, hey, here's this cortisol story. And when we add the metabolites, we get a richer understanding of what's going on. And there's a parallel story for estrogen and metabolites and androgen and metabolites. And then once we started the company, then I kind of went back to that HRT conversation and went, okay, where does this test that we have tell a story that seems to be true and is helpful for clinicians, and where does it not? And let's try to educate around that. And then this, like for us, if saliva told a unique story, like it tells a unique cortisol story, which is why we have the DUTCH Plus, because that opens up a window that we want to see. And if it told a uniquely true story about HRT, then we would look at commercializing our saliva tests for estradiol, testosterone, and progesterone. So the origin of this, to me, and I think it comes from even people I really disagree with, I think a very genuine place of just trying to find truth for your patients. So if you go back to, I don't know, the late 1990s, early 2000s, the story really started with progesterone, I think, and there's a confusion there that some of it can and some of it can't be applied to testosterone, which is what makes this so confusing. But if you give a woman topical progesterone, a lot of them feel better. And then you go, okay, well, that's interesting. What happens to the lab tests? And what you find with topical progesterone is it doesn't push urine, but more importantly, it doesn't push serum levels up. Right. So then you get this confused group of people, like rightfully so, in the early 2000s, right when I was starting to get into this industry, going like, what the heck do we do with this? Because, so if you take a woman, Mark, I would imagine a woman with PCOS who's got estrogen levels that are a little dominant to progesterone, she might legitimately feel much better if you give her topical progesterone. And then if you go try to monitor that, what you find is you find the serum really doesn't move, and you go, well, that doesn't tell me a story that's helpful. And the saliva is sky high. So you're like, well, I guess that tells me a story that like jives with reality. And it's a confusing story because yes, women feel better on topical progesterone often. But then when you say, okay, let's go to its most common use case, which is I have hormones up here, I hit menopause and estrogen and progesterone drop, I give her estrogen. Now I know I've got to give her progesterone. And you say, well, how should I do that? And if you use topical progesterone, the serum doesn't move, and you say, well, that doesn't work. And then the saliva goes sky high, and you say, well, does it work? And the thing that's confusing is there are split studies on that. The Leonetti study says, yes, it does work even when serum doesn't go up. And people responded to that one study, and it really is the genesis point, I think, of almost all of this movement and model around saliva testing. The thing is, the two other studies that are bigger and longer studies showed that it doesn't actually work. And the Wren study actually said, hey, we have saliva progesterone values that are very elevated, and the uterus isn't protected in these cases. So right there, we got to pause and go, holy cow, this is really confusing, and we've got to figure this out. But a fraction of our industry just really ran with that message of, look, this is free hormone. Saliva is a tissue surrogate, and so it speaks for tissue in this case, which is why it goes up and serum doesn't, and they really ran with that. And from there are layers to this that get really confusing because progesterone doesn't go up when you give it topically in serum, but testosterone and estrogen do. So they go up, right? And the saliva goes much, much higher. And so that's not to get into, I mean, there are other layers of this that we need to unpack, but that I think is really the genesis point of this. And even from there are lots of confusing points. So people will say, when you take topical hormones, it doesn't show up in serum. And that is relative, I would say that is true of progesterone. But for estrogen and testosterone, it's not true. They do go up, they do scale with dosing, and then we get to this all-important question of like, okay, if both numbers move, which one is dancing with the clinical outcomes? And that's why for us, we started with testosterone, not with this case. We've been making this case for progesterone, for estradiol, for testosterone for years. This process of this paper we just published was taking that case and putting it through the peer-reviewed process so that we can contribute to this dialogue. So for testosterone, we know clinical endpoints. We know about muscle mass increase. We know about LH suppression. We know about erythrocytosis, all the things that happen when you take testosterone. And if you follow the clinical data, it looks a certain way if you're giving too much testosterone, and it looks a certain way when you have insufficient testosterone, and it looks a certain way when you get it right. And so then you can go and overlay the saliva data and the serum data with that and say, hey, which is dancing more with like in concert with the clinical data. And what we found is that for every single clinical endpoint that we could find, there's a pretty good alignment with what happens in serum, and that's in disalignment with the salivary testing. And so that was our attempt, is to really lay that out for people, so that we can make some sense of this, and again, just continue to pursue best practices and things that seem to align with reality.
Yeah, absolutely. Well, before we get into the paper, Dr. Holthouse, you've been in functional and integrative medicine for literally 3 decades. Such a highly respected person in this field, and we're really grateful for you joining our conversation today. Can you talk a little bit about how saliva fit into your practice when you first got into training when it came to hormones? And was there something in your patient experience that kind of shifted or made you question that saliva first model?
Absolutely. Glad to be here, you guys. It was kind of simultaneous, I think, with the dried blood spot that I was seeing people largely coming to the practice with these really elaborate printouts, beautiful colors, and you have a little bit of imposter syndrome when you first get into this field, and you see an unfamiliar test, and you feel like, oh my gosh, I need to know more than the person sitting in front of me. So you learn these tests. You get these vendors at the conferences to get you up to speed. And what I learned right off the bat was that there was just this inconsistency with not just monitoring and results, but actual clinical endpoints, how they felt. Largely with the discussion of progesterone, it's largely a symptom treatment drug as far as I'm concerned, and it's very difficult to monitor. But with testosterone and estrogen, it was just apparent early on that it was tough to have the validity and the reproducibility even within the same patient, using saliva and then expanding that to the dried blood spot later on to get any kind of conscious, meaningful discussion with the client. When they would see these results and they would have symptoms and they would look at where they were and where they are, it was hard to make sense of it. And that's where I really started focusing on urine and serum. Serum, because it's covered by insurance, you got all this data, and that was a low point of entry for patients. So that was my experience early on. And honestly, it was probably 2 years of hardcore really trying to make that work. You'd go to these conferences and you'd hear what Mark just laid out beautifully, and that was the dogma. And then when I went to apply it, this was on men and women, it was just not like that. So my reality with my practice and implementing and what I was being taught back in those days was very different.
Can I lay out for you what I would say is the average patient in that world and see if that kind of aligned with your experience?
Absolutely, yeah.
So the average patient, as I sort of look at all the data, is the guy that comes to you that has a serum testosterone of 300 and has symptoms of low testosterone. Like, okay, this is a guy I can help, right? So if you put him on 10 milligrams of testosterone, the average saliva value goes way outside of the young healthy norm, and that's considered a pretty low dose. And then the blood spot value on average goes with 10 milligrams, I think, to about 1,200. So it creates this nice space to go, okay, this is a pretty good learning environment, because the serum results imply, and in the urine, that a transdermal gel is going to absorb at about 10%. So if I give you 10 milligrams, I'm giving you a higher level female dose and an almost negligible dose for men. Okay. Right. And then if I look at the blood spot or saliva, I get these really high values, and they're usually collected 24 hours after, so you're ready for the next dose. So this is the low point. Like if you tested at 12 hours or 8 hours, those numbers would be about 2 to 20 times higher. So these are really hefty values that tell you, hold on, this 10 milligrams is actually a pretty hefty dose. Like, you might want to scale it back because you're being super aggressive. But that patient that's coming in at 10 milligrams is giving you on the higher end of where you'd want to go in blood spot and even higher in saliva. And then if you push towards 25 and 50 milligrams, and 50 milligrams is what the data says works. At that point, those values are just in the stratosphere. So on average. So I'm just curious for you, which doses did you try, and what sort of just general numbers did you get? And does that jive with kind of what the sort of aggregate data says in terms of what you experienced?
Exactly. You know, I started off with much higher doses with guys than 10. You know, I was used to looking at serum, and I was used to looking at published dosing and what worked for people. And, you know, anywhere from 25 to 50 milligrams was where I was hanging out. And so, yeah, I was getting stuff that was 20, 50 fold higher in the saliva, sometimes higher. I mean, I was seeing readings in the tens of thousands. It was just like, what is going on here? I thought for sure there was a contaminant.
Well,
You
you
know,
can
which
imagine
also
how concerning that would be to a clinician thinking contaminant or you're way overdosing that patient.
Well, what I was told by the experts when I called on this, I called the vendors for these labs and said, "What am I measuring here?" And that has to be somebody that has done a finger stick with the same finger that they used to put the cream on, or you know, the saliva must be measuring somebody who put they put the topical cream on their jaw or on their neck. And I said, no, they're not doing any of those things. And so despite getting that kind of feedback, you know, I just was never able to justify going back to the client and saying, hey, did you maybe do this with your collection? And it was like, no, I did exactly what you said. And these are the kind of results that I'm getting. And even worse, when we would use the same dose on the same client, putting it on exactly the same way, looking every 3 months, trying to make some sense of trending, there was a lack of, it just didn't make intuitive sense with where I was going with my dosing, escalating or de-escalating. I would often see opposite reactions. And that's what really did it for me. And I was like, this just makes no sense that we dropped your dose 50%, and you're thinking about dried urine, dried blood spot in particular, went up. How does that even happen? So you know, the rationale that I was given was that there was a contaminant in the way it was collected. But no, that's exactly my understanding. Is about 10% is absorbed topically, and that's what you're going to get in the serum and see reflected. And with these other ways of measuring, it was very inconsistent.
Mark Newman, a question for you here. So, I mean, I think one of the things that may be surprising to people reading this paper, or maybe who haven't read the full paper, but like, we're not selling dried urine testing for testosterone dose monitoring in that paper. You know, we're not really promoting that as the primary means. And if you've ever trained with DUTCH, if you're a listener, if you're a provider, we recommend serum testing to get the dose right with testosterone. There is a complementary amount of information that can come from the DUTCH test. From a primary point of view, like, the DUTCH is not the hammer for all the nails, and this is a case where serum is really the best standard. Do you want to speak at all to that? Or maybe just briefly around why this issue mattered to us, even though it's not really something that directly affects us as a business. And I think secondarily, like, how is DUTCH supportive when it comes to testosterone replacement?
Yeah, I mean, urine testing has kind of two potential uses when it comes to HRT. The first question that people want to ask is, did I get my dose right? And I am in perfect alignment with you, Dr. Holthouse, when it comes to progesterone, is when you say, how did I get my progesterone dose right? The labs don't help. It's a complex question because it's a different reason why they don't work for oral progesterone, and why each test doesn't work for oral progesterone, and why they don't work for vaginal progesterone. But if progesterone was given as an injection, for example, the labs would probably be somewhat helpful, but it isn't. And it just so happens that you need to track what the literature says works and how your patient's doing, and that's the best you can do. And it's better to know that than to spend your life trying to jam square pegs into round holes. So when it comes to testosterone, the first question is, how do I get my dose right? And then another question is, like, what about the rest of the story? And so so for me, I think when you give topical estrogen to a woman, the urine value has some value in saying like, hey, am I giving her the dose I think I'm giving her? Is it absorbing in like am I helping with bone, or do I need more? Or do I need to back off because she's absorbing too much? Like, that's a question that a lab test can potentially help you. And then the secondary question, which is where we really like the urine story for testosterone, is what else is going on? So if you raise a man's testosterone, I like Serum to hang your hat on and say, did I get my dose right? Or maybe someone who uses pellets, the question might be, am I ready for another dose? Those types of questions, the values seem to like do best with Serum. Okay. Then you have other questions of, one, I would imagine, Dr. Holthouse, if a guy comes to you and he has kind of low testosterone and he's stressed out of his mind, getting rid of low testosterone symptoms, if you don't deal with the HPA axis, anxiety, stress, is also going to be difficult. That's a great use case for what we do. Secondarily, if too much of that testosterone is spilling over into estrogen, that's a question you can ask with serum or urine. But urine goes further to say, how's his phase 1 metabolism? How's his methylation? Like, how's he processing that estrogen? We actually just published a case study that was a tracking of that, of the elevation of testosterone and too much estrogen and crappy metabolism. And then we addressed the metabolism step by step, and it pulled that estrogen down into range. And so you have this sort of better picture. So it's what are you doing with testosterone, DHT production, estrogen phase 1, estrogen methylation, and what's going on with the HPA axis. And then, of course, we've got some of those other ancillary pictures of oxidative stress and melatonin and some of those other things that fit into the whole person, but they don't speak as directly to the hormone story. But so that's for us, is the DUTCH test. It has more of a complementary nature when it comes to its best use case for androgen therapy. But our goal for this is to really help people get it right, because we've just seen, people like you that have come through. I mean, you were educated really well on parts of this and then got exposed to this argument. So it's a little easier, I think, for you to sort of tease through it. And yet, it took some time, right?
Yeah.
And if someone because if you went to the literature before this paper, no one is laying out in the literature, the case for like how well do these different tests seem to go up and down with the clinical utility of the test. Like, there's a really nice combination of papers that we reference, where there are two different testosterones that are used topically. One of them absorbs a little bit better than the other. And there are two studies that used each of these products. And they're both following sexual side effects related to testosterone. And in one of them, the serum went up into that target range, and the sexual side effects were relieved better than placebo. And in the other one, it went up, but not into that target range. It was too mild of an increase in serum, and wouldn't you know, it failed for the sexual side effects. And the frustration with all these studies is nobody's bothering, and I mean, I don't blame the researchers, but if they had looked at saliva in those men, what they very likely would have found is in both studies, the saliva is high. Like holy cow high, right? Like really, really high. And then you would say, oh, well, that doesn't, in that second study, the saliva is really, really high and the serum is lagging, and the serum correlates better to the sexual side effects than does the saliva. And this has been part of what I consider my job for the industry is, okay, what we have to do is grab the saliva values out of different studies and overlay them with what these studies say, not because that's ideal, but because that's all we have. Because nobody's doing this. The only study to date where people have taken serum, saliva, and clinical outcomes in the same study is that Ren study clear back in, I think, maybe it was early 2000s.
Yeah.
And they said, when the saliva climbs, we don't see the clinical outcome, but nobody's looking at a comprehensive lab story when it comes to those clinical outcomes, because I mean, there really isn't. You can justify not doing it because there's no data that says you should, but that's where a lot of the confusion comes from. And what we tried to do here is take all the data that's available and overlay it and say, where do we see coherence and where do we see, a lack of coherence? And that's what was the goal of this. And again, the point is, let's pursue, best practices together to the best degree that we can.
We'll be right back with more. The Introduction to Menopausal HRT course, created by the DUTCH test, is designed to empower registered DUTCH providers with the essential knowledge and skills needed to effectively support women navigating menopause. This course, presented by Dr. Jaclyn Smeaton and Dr. Carrie Jones, addresses lingering misconceptions around MHRT and enhances provider confidence and competence in managing menopausal hormone changes. Sign up in your provider portal to learn about the foundations of menopausal HRT, estrogen, progesterone, and androgen therapy, and the importance of individualized care and hormone monitoring. Or become a DUTCH provider today to get access. Welcome back to the DUTCH podcast.
So, Dr. Holthouse, I want to kind of get your experience so that other clinicians might be listening, being like, oh yeah, I'm finding that's happening. And you've covered this a little bit, but I want to just reinforce, like, when you first started in practice, you were using saliva and dried blood spot. When patients came to you and they'd been managed on that type of testing, what were you seeing clinically and how were they feeling and what did their testosterone levels like actually look like?
Yeah. So the testosterone levels were, depending on the technology, they were consistently supraphysiologic. I mean, that's across the board. Progesterone was a unique critter, as Mark alluded to, and it was pretty much something that I learned early on, even before I learned from Mark and David Zava and some of the experts in the field, how it's different from testosterone and estrogen, because that's not something as a clinician I'd ever heard before. I learned it was really most prudent to follow progesterone with symptoms. And whether it was topical, there's a little bit of nuance with the oral, which is by far my preference. But it was a supraphysiologic lab result that I was seeing across the board, especially with progesterone and with testosterone. Estrogen maybe not as big of an issue. And one of the things that I think you mentioned, Mark, in your blog was that estrogen is not quite as labile as testosterone. At least not when it's given in a cream or topical form. When you're looking at saliva, it's kind of got this up and down thing that you describe, and that's actually what I saw clinically. It was the bookends were progesterone and testosterone, where we saw the outliers and these super physiologic things. And where that became a problem was my postmenopausal gang that was on systemic HRT that, for whatever reason, they didn't want to take oral P4, micronized progesterone, at 100 or 200 milligrams orally to protect the uterus from overestrogenization. They were coming to me, and this is really what started my whole journey in this, what is really going on query. How am I knowing that these supraphysiologic progesterone doses are protective? And in fact, I'd heard of some cases in California where I was practicing at the time where there were some practitioners that had gotten into real trouble with endometrial hyperplasia over using this combination of systemic HRT in combination with either a vaginal or at that time, which is still kind of controversial, but at that time it was actually just a topical progesterone. And they were using saliva to manage the dose, the therapeutic tissue levels, because, right, we were all trained, that represents free tissue hormone. And so that was kind of my first wake-up call that maybe that wasn't true. And here was a population of people that really you can't afford not to get it right. You could be, causing cancer. And so that was really the starting point. So it was not long after that, realizing these supraphysiologic representations were not representative clinical results. On the guy's side, it was certainly the serum, because I started experimenting and doing other ways to monitor, not just diagnose, but then to monitor. And it was a consistency with the serum. It was an inconsistency with these other two modalities that I mentioned. So that was really the evolution. It was nothing more complex than that.
I want to just kind of wrap that thought on the progesterone, because I think whenever we talk about progesterone for postmenopausal women, I like to make sure we leave listeners with crystal clear guidance, which is our point of view. It doesn't differ from that of, Menopause Society on this one. You want to be using 100 or 200 milligrams of OMP not using transdermal for endometrial protection. If you have a perimenopausal woman who needs help with sleep or something like that, that's fine. But if they're on an estrogen replacement therapy or you're looking for endometrial protection, you have to go with those trusted, validated, clinically validated doses. And we agree, like, testing does not help in that case. The vaginal progesterone does have some research now where we think that's a pretty good alternative for women who don't tolerate the oral, but you're right, the body of evidence is not the same for that when it comes to safety. So you have to like really have informed consent with your patient.
I think one, if we're being fair to that, to the use of transdermal progesterone, is some people do have the practice of using relatively low dose of estrogen and then adding endometrial surveillance. And if you add endometrial surveillance, then that is a route that you can go. But if you're not, then I think the evidence of protection, it's not high enough to just give the hormone and then trust that it's going to work. So I think in terms of your practice, I think that makes a lot of sense what you're doing, Dr.
Definitely.
Yeah, a lot of people that are using the the vaginal progesterone in that case, they have in-office ultrasound, so it totally makes sense. And if you know what you're doing, you know what you're watching for the endometrial thickness, totally responsible.
Yeah, one of the things that was kind of an early tip to me in terms of the fact that saliva didn't make sense in an intuitive sense is that if you think about the vaginal tissue, it's very vascular, right? You would guess that that tissue would absorb hormone better than the skin, which is meant to be a barrier, right? And if you move the hormone from the skin to the vaginal tissue at the same dose, you would think, oh, I'm probably going to absorb more. And what you find in the urine and the serum is that it goes up like 5x, something like that. Don't quote me on that, but it goes up. It's definitely up, right? And then if you take the same exact scenario, the saliva values when you move from the skin to the vaginal tissue is about 10 times less, which then tells you the message, hey, the skin is a much better way to get the same dose into your patient than the vaginal tissue. And if you just say that out loud several times, you go, wait, hold on. Like, that doesn't make any sense, this vascular tissue that you would think. So that was one of the things for me that made me go, like, hold on. Like, something's not telling the right story here. And the outlier, if you look at the data, actually, if you give vaginal hormones, there's one study where they looked at serum and saliva. It's a very similar story. Like, the magnitude of the increase in saliva and serum is fairly similar there. And then you move it to the skin, and that's where you get this huge discrepancy. And so anyways, that I thought was a pretty good tell that, like, these values are not reflecting, what's going on systemically when it's on the skin.
When it's on the skin, yeah. That's a really good point, actually, clinically, because in practices I'm involved with right now, and where the contemporary teachers are sharing, there's more and more of a leaning towards using vaginal applications of hormones, in particular progesterone. I like it, obviously we like it for the allopregnanolone effect. We want that first phase metabolism because they sleep so amazing. They love you afterwards.
Meaning that's why you like oral.
That's why I like the oral micronized, exactly. So there's very rarely in my practice is there really an indication to go vaginal with progesterone or topical creams in a combo because they get so much better symptom relief within so many of these patients that are needing HRT have sleep disorders. So it's just a better way to go.
Well, I want to talk a little bit about the clinical impact of potentially deciding to dose testosterone off these super physiological levels. The typical clinical response would be reduce the TRT dose. Yeah. And that could be reducing it to a level that's below what's been demonstrated to have clinical efficacy. That's ultimately the big concern here. So this study highlights that this subtherapeutic serum testosterone is associated with a failure to achieve protection for things like bone mineral density, muscle mass, sexual function. These are all areas where, like Mark alluded to before, a minimum serum threshold is required to confer benefit. So I think it's really important for clinicians to be thinking about what does it look like, not on the labs, but in your patient when they have inadequate dosing of TRT. Can you talk about what are the symptoms and what's the clinical picture that you see coming in? And if you had to see a patient and you could say, it looks like things are adequate now versus probably not, we should double check their levels. What are the indicators to you? What are they telling you, or how are they feeling, or what are you seeing on a clinical exam?
Yeah, this has so many tempting, Jaclyn, you got to keep me on track here because
I'll try my best.
I'm thinking about the differences with clomiphene and N-clomiphene and HCG with the answer to that, which there's all kinds of layers to this discussion clinically, which are really fun, but we won't go there, I swear. But no, it's the lack of reduction in central obesity that often I'll see. It's the lack of improvement in insulin sensitization that we often see with adequate doses of testosterone. So it really comes down to not just the structural concerns of bone loss and estrogen, obviously being a huge player as well in men with maintaining good bone health, but it's really about these people that have got fatty liver that are metabolically ill. The new book, Good Energy, talks about this, and so many of our clients are suffering from these areas. And this is as big of a reason in my practice where I'm using it as much as sexual function, maybe even more now, is with fatty liver, with insulin resistance syndromes, met-sin, pre-diabetics, type 2s, people that cannot lose central obesity, people on DEXA scans who their body composition just shows persistent visceral obesity, where we're trying to move these things, especially in guys, but also in women when it's dosed appropriately. So I often will see a failure to meet these endpoints. Mark mentioned bone density. So yeah, we will see it in lean skeletal muscle mass, not just lean mass, but actually skeletal muscle mass in pounds. We see when we don't meet the mark by underdosing. It's obviously the other thing is true too. If you're overdosing, especially in women, you can precipitate a lot of anger and hostility and just really irritable people that are getting overdosed. So I think as we move testosterone out of the arena of a fear of prostate cancer and coronary artery disease being provoked, and now we're knowing that after the Traverse trial in July of 23, hey, it looks like actually it's safe and it's effective. And we've got all this data now that shows it's actually a therapeutic for things like insulin resistance and certainly maintaining good bone health and mood and sexual dysfunction and men and women, that we really have to get the dosing and the monitoring spot on so that we're giving people their best attempt. They're paying a lot of money in the case of pellets and some of these modalities. And so I think it's really important to get the monitoring piece correct.
So you said two things that like were kind of really helpful for me in the literature. When you talked about bone and you talked about signs of women having too much testosterone, what I love what they do in studies, not because it's the best way to do a study, it's just best for my brain, is when you use doses until it fails. It's so handy in terms of understanding what's going on. So because the one study in our paper that we referenced, I think it's Sattler, I forget the author. It was on bone. And what they found is they found success at 50 milligrams. They barely succeeded at 25 milligrams, and then they failed at 12.5 milligrams. They said that is insufficient. And that is so instructive to say, great, because if I take that dose that I now know is heading towards a female dose and is insufficient for a man, and I give it to a population of people, I have that data. And it says that the saliva data is sky high for those men, and then I'm able to go, oh, okay, then that value totally conflicts with the clinical data. And on the other side of it, I'm able to say, okay, if I go down from 12.5 milligrams just a bit to 10 milligrams, if that's a male dose of hormone, right? If saliva and blood spot are saying, hey, this 10 milligrams, it might be too much for a man. I can go, oh, okay. Well, then what happens when I give that to a woman? Because if you shift over to injections and you take a male dose of injections and you give it to a female, you're going to get symptoms that she doesn't want.
Shaving the next morning.
Yeah, unless,
Not good.
in all seriousness, you're talking about trans men, and there is really good data that says, look, when we give 5 to 10 milligrams transdermally, as a chemist, I'm not saying that's the right dose. I'm not saying that's the wrong dose. But if you look at every single study where they've given that dose to women, you never see high testosterone symptoms, except in the rare cases when what? When the serum level goes outside the range towards the male range. And then one of the things we did in this paper is then we shifted our attention to the body of literature on trans men, where the goal is to take a biological female and accomplish those high testosterone symptoms. And you ask the question, well, okay, what did it take to do that? And what they say is, even with 25 milligrams of a gel, like, you get mild symptoms of excess testosterone, and only if you push the serum into those male ranges do you start to see what you call in this sense success. And so when you add all those up, you go, oh, so the very simple truth that I have here is the saliva values for those people are very high values that have nothing to do with the clinical reality.
Right.
And the serum data seems to speak well for what's going on clinically. And that's the whole point, is we want something that's going to move with the clinical picture that we can hang our hat on to say, did I do what I'm trying to do, which is either to take a woman who's low and make her normal, or take a biological female and put her in the male range, or take a male who's insufficient and put him in the range where he's going to see the bone increase, like, and those things. So the bone and the females with symptoms of excess testosterone were two really good points in this paper that we were able to point to say we see really good congruence between what's going on with serum and what's going on with the clinical picture, and we see a contrast when we look at those other lab types of saliva and dried blood spot.
Yeah.
Yeah, I love that you bring up, I mean, I think we have such an interesting body of literature when it comes to, like, looking at the trans male population. It is a unique opportunity for us to see that, like, titration of dose and the impact in a biological female. And it's very interesting to have that data to be able to reference. I think that's one of the most interesting aspects of the research that we did with this review. Now, Dr. Holthouse, I think one of the things that would be helpful to cover, because we're talking a lot about getting into this target threshold serum range. And I think one of the challenges when it comes to testosterone is that, like, the generally accepted range of normal is like 300 to 1,000 nanograms per deciliter. It is so huge. Some actually labs report up to 1,200 nanograms per deciliter as normal. So we have, like, the kind of endocrine society, they say normal, lower limit of normal is about 260. On target therapy ranges, you see 400 to 700. There's the Framingham Heart Study. We have all these studies that point to different targets. Clinically, in your own practice, can you tell me what you look for and how do you blend? Because, I mean, it's really interesting how sometimes you'll see men come in and you're just doing routine screening and their testosterone is like 250, but they report no symptoms of low testosterone.
Yeah.
And then other times you have men, like, treated and they're at 800-900 and they're still feeling low. So how do you wrangle that clinically?
Yeah. I think it's largely a function of inflammation and cortisol. So many, I tell guys that cortisol is the great kryptonite to symptom relief from testosterone replacement. You know, whether it's central obesity and they're aromatizing like crazy, I always say you've got to be careful with the people I train. The body that you're putting the testosterone into, what's it going to do? What's that body going to do with the enzymes and the terrain? You know, so these folks that have got a lot of central obesity and a lot of aromatase activity. So you have to be wary of that. And that's what I actually appreciate about the DUTCH test, is that you've got that cortisol piece, HPA axis kind of built in to what's needing to be part of the bigger conversation. I ideally would love to have every man's baseline at 25 when they walk in. What were you at your peak? And unfortunately, 90% of the time, we just don't have that unless they've been with me forever as a client. And so that would be wonderful, because some of these guys were 800, maybe 1,200 when they were 25 years old and peaked. And, you know, before they got comorbid diseases, which we know has a huge correlation with promoting hypogonadism, you know, they were in a different place. Now they're just walking in at 40 and they're at 550 and they've got symptoms. What do you do? Well, you have to look at that bigger picture. Knowing that 1720 lyase that moves you from the pregnenolone progesterone family over to the androgen precursors, knowing that aromatase and knowing that 5-alpha reductases are all influenced by things like insulin resistance, stress, oxidative stress, inflammation. You have to understand all of those things about this guy to know what's happening with testosterone, which is just sitting kind of in the middle of all this noise. And things are metabolizing it away, and things are inhibiting or supporting its production, or not. So I'm always thinking of it in that bigger context of how did they get there with that number that I'm seeing on a two-dimensional page. And really, I tell guys, I'm going to treat you as a person as the first priority, as opposed to any lab result. And I say the same thing to women, because these reference ranges, especially for women, are fairly ridiculous when it comes to managing optimization. But I usually look for something north of 550, 600. There's some data out there that suggests there might be increased all-cause and even cardiovascular mortality in folks that are even less than, or 600s. And that 600, 650 should be kind of our benchmark for optimization. Androgen, the androgen stuff that you see with FDA and Endocrine Society is out there, but then there's the real application. I have many guys that don't feel great until they're up around 1,000, 800, and if they're desiring, fertility in the near term, and we're using HCG or clomiphene, and they're younger still, we can get them up in the 800s, 900s pretty easily with those non-testosterone products. But if they get their numbers up with those products, sometimes they don't feel the same symptomatically as they do when I've used a testosterone product and gotten them to that exact same threshold. So even using different modalities of getting their total testosterone to the same number, and I can't explain that exactly. I think probably there's some estrogen things at play with the Serum, with the Clomid in particular. But
Meaning that because Clomid works on the estrogen receptor, that maybe it's also doing something to symptoms. Do you find and we're getting off topic, which is totally fine with me. HCG doesn't do that, and clomiphene does hit on that estrogen receptor. Do you find between those two that you get better symptom relief from the same testosterone level from HCG, which doesn't hit the receptor?
Yes, we kind of, in the biz, we're thinking of HCG and testosterone replacements as equal in that fact, where sometimes Clomid, they'll have the same number, and because it's bumping FSH and LH, not just LH, you'll see that. Now, the enclomiphene compounded isomer of that has pretty much solved for that. It seems to, it does not have that same estrogenization effect. And so I pretty much exclusively am using that over the standard clomiphene citrate. Yeah, but so to your point, Jaclyn, I think, I don't treat to a threshold per se as much on this topic as I would say for estradiol in a postmenopausal female where I'm trying to maintain bone and get them above 60. I have colleagues that I really respect that think that that's probably somewhere more like 40. You don't need that many picograms, but suffice it to say, with testosterone, I'm going to go after the symptoms as my number one goal with these guys, and that's after all what's going to bring them back.
And
I feel better.
One of the things I think is challenging about estrogen is if one of your key things is bone, is you can't just ask your 60-year-old female patient, like, how are your bones doing? Obviously, there are some additional testing you can do that speaks into that. But, because what I've noticed from the literature is if you give someone a placebo, it's half the effect on hot flashes that a proper dose of estrogen is. Right. So you have to be careful about saying, like, do you feel better? Yes, I have fewer hot flashes. That doesn't necessarily mean you're sufficient. I think one of the things that is challenging about estradiol is in this whole argument that we're having, I can just hear some people saying, hey, listen, you're wrong. Like, when I give estrogen, I don't see it in the serum. And I think there is a difference between estrogen and testosterone, and that is that when you give a man testosterone, on average, it's a gentle up and down pattern throughout the day. And when you give a cream or a gel of estradiol, it's actually relatively rapid. So it is easy to test in serum and not see it, even if it's there, not because it's not there, but because it's fast. And so, and that's where we've said, I think an area where urine can be helpful is that you want a test that captures over time. Urine is set up very well for that, to sort of integrate the area under the curve. So I just want to acknowledge that people do have to be careful that if you set a target in your mind for estradiol and you go chase it with a patch in serum, that's not a bad approach because it's a pretty flat pattern. But if you go chase that target number with a cream or a gel, it can exceed that number, and before you test, come back down. So you have to be really careful. I don't think serum's a great option for gels and creams of estrogen because you can end up overdosing, again, not because it's there, but because it goes up and down so fast. And then, and this is where all this gets confusing, is on top of that, what you just alluded to, is there is also then a good faith debate about whether the impact you see from 20 to 40 in serum or 40 to 60 or even above 60 when you start talking about cognitive benefits and some of these other things. I would say that's not a debate that's settled, is where that target really is optimized. And of course, it's going to be an individual, game that you're playing with a particular patient. So it's this 3 or 4 dimensional picture that is confusing. You have these up and down patterns, you have confusing targets as to where you should really be shooting for, and then you do have some differences, not just between progesterone and these hormones, but also between estradiol and testosterone that can confuse that. So, and this is where we really love to have people like you, when we have conferences, lay out for people not only what the literature says, but also just very practically what actually works in practice for getting the dose right, and then also looking at some of these confounding factors of metabolism, HPA axis, et cetera, which is what also makes it all interesting.
Totally. I mean, if you're interested, so estrogen, we don't have time to talk about that in today's podcast. That's a whole nother subject that Mark just tapped into, but we do have a lot of resources on that. So if you want information on estradiol monitoring or our point of view on it, or how urine LCMS might be a really nice way to monitor, I'd encourage you to come to DUTCHtest.com and check out the education that we have. There's a lot of free education, and if you're a provider, you can get access to our behind the scenes portal where we have even a full 6 to 8 hour course on HRT that's unbranded. It's not Dutch promoting, it's just the evidence on it. So I just highly recommend those resources. Dr. Holthouse, I want to speak to one of the things that you also said about testing men at 25. I think it's so important. And I hope that we have a lot of younger people listening. I feel like now, no people in our generation didn't get interested in hormones until they were gone, really.
Right.
But I think younger generations are just engaging in their health so much more proactively. And that goes for men and for women. So if you're one of those people listening, I think this is where getting that baseline is so important. Your baseline for metabolic health, cardiovascular health, hormone health, liver health. Do that screening. And now that there's all these direct-to-consumer serum testing companies, it can be very inexpensive to get this broad swath of data. And even if you don't know what to do with it today, or if things look great, it's just nice to have that to compare it to decade by decade so that you can see how you're changing. And one of the things I think about a lot, and I used to talk about this a lot with thyroid health in my practice, because the normal range for thyroid for TSH is 0.5 to 4 or 5, depending upon the lab you're using. And sometimes women feel terrible at 3. And you're like, oh, you're in the normal range? Are you okay or not okay? And so I think getting the baseline is great to compare it. How has it changed? But I always used to say to patients, the normal range for a shoe size for a woman is a 5.5 to a 10. If you are a size 9 foot and you put on a size 6 shoe, it's going to be uncomfortable. And likewise, if you're a size 7 and you wear a size 10 shoe, it's not going to be a fit. And I think we have to keep that in mind when it comes to normal ranges, is that when we are measuring ourselves or our patients, there is a large section of the normal range that's abnormal for that particular individual. So just keep that in mind. And it's you always have to treat the person and have the lab's support. And I think that now that we have the advent of all these self-directed tools and algorithms that are interpreting our labs, you can really lose that. You can lose that nuance. I think it's just so important to capture that.
Yeah, to Mark's point, I think that we owe it to our clients to evaluate tissue efficacy, and I think we've got ways to do that, whether it's, body composition analysis, whether it's looking at LH, FSH suppression, whether it's looking at, bone density. These are things that I think we owe it to our clients to be evaluating. And even, having an ultrasound available, and it's a non-invasive way to evaluate what you're doing to a woman's uterus chemically. You're chemically, I have the landscaping analogy where the estrogen is the fertilizer for the lawn, and the mower is the progesterone, and the dose of progesterone is the mower deck, how low you're going. Don't scalp the lawn, it'll bleed, and don't do too little, it'll get too much fertilizer and it'll bleed that way. So it's this bigger art that we're trying to betray, this very tunnel visioned approach, and move towards where it is truly the art of medicine. Hormones are truly the art of functional medicine in my mind. You have to understand all of these moving parts. The lab piece is probably the last thing to really come into to focus for me. And I think for a lot of clinicians, it's incredibly confusing. Even in my own IFM teaching faculty, we have disagreements, and that's okay. But sometimes it really impacts how your treatment goes. I think that's probably why I've gravitated towards patches and serum for monitoring, and doing some of these things where I'm getting away from some of the pitfalls that Mark alluded to with overdosing, with using serum and topical estrogen, for example, and then using oral progesterones. There's like an easy way to do it, and then there's a hard way to do hormone replacement therapy and monitoring. And monitoring is where the art is. Anybody can identify symptoms and initiate treatment. I think it's the safe and efficacious monitor that separates the men from the boys, so to speak, in my mind.
That's great. Well, as we wrap, Mark, can you really just share? I mean, one of the things that we did, we wrote this blog when we released the paper, and it really wrapped with this open invitation and a call for discussion and feedback, because that's ultimately what we wanted, was to put information forward to stimulate feedback and discussion that can help move us forward from a clinical perspective. Can you wrap us with just what your hopes are with this publication, and what practitioners and what our industry might do with it?
Yeah, I mean, it really is the pursuit of best practices for all of us. And there's probably a little component of like myth busting in there. And when it comes to that, there are two different sides of any of those issues. And one of the things that is sort of passively pointed out by our paper is that people have been supporting, and I think in good faith, supporting a particular model for now 20 years without like any data that's been through the peer-reviewed process that actually supports that model. And I think that's a problem with just our industry can't work that way. And one of the things that's actually in the paper that sort of is kind of quietly in the paper is there's new publication in that shows women who are on topical testosterone, who have elevated saliva values, and they do not have a higher frequency of high testosterone symptoms than women who are on topical testosterone who do not have high saliva values of testosterone. So when we have a model that we think like does something, proves something, shows something, and it's a provable claim, then it really is, I think, important for us in the industry to be putting data forward that supports that. And there's silence on that front for 20 years. And so I think what people do from that is in this, I think, effort to be kind and to be Switzerland-ish, is you just say, well, perhaps this model is out ahead of the research. Yeah. But the point of this paper is there's a lot of research that actually evaluates that claim, I would say sort of indirectly. And the point of the paper is when you indirectly evaluate that claim with the available data, where there is a lot of data, it all falls in one camp. I mean, I will be honest with you, when I started this journey, I went into this with an open mind, I mean, at least from my own perspective, and said, okay, I've been told both things are true, and I'm gonna go dig into the data, and I'm gonna find every paper that supports this claim and every paper that supports sort of the opposite position. And what I thought I would end up with is a short stack of papers over here and a big stack of papers over here, and then I would weigh the evidence. And what I ended up with is zero. When it comes to testosterone and estradiol, I will say, the Leonetti study stacks on this side that says serum didn't go up and the symptoms exceeded what you would predict from serum. And that's the central question that I'm asking. Can I find evidence where the clinical response exceeds what serum or urine would predict in these scenarios? And for estradiol and testosterone, the stack is dozens and dozens deep on the side that says no, and the side that says, yeah, there's an issue here, and maybe saliva has something to offer that's a unique message that we should listen to. I haven't found a single set of data that supports that, and it is an open invitation to say, look, if there's evidence for this model that says the opposite of the direction we're sort of headed, then let's get it out in the literature so we can add it to the dialogue. Otherwise, all you end up with is conjecture and anecdotes on this side, and you can stack those in creative ways where people think there's evidence, and that's what I'm saying is that there isn't evidence. So one, like let's bring evidence forward that helps us understand that, and let's also be honest with the fact that if there isn't, then let's discard models that aren't consistent with the data, because even what is consistent with the data has a lot of confusion in it with urine testing and serum testing and different pharmacokinetic patterns and metabolism and different routes of administration. Like, this isn't easy stuff.
Yeah.
So we've got to take the things that aren't consistent with reality and discard them as we continue to pursue that. But yeah, it's an open invitation to say, take things that are meaningful, get them in the peer-reviewed literature, so this is a conversation that's like a validated conversation and not one that just relies too much on conjecture and theory and anecdotes.
Well, thank you both so much for joining me for this thoughtful conversation today. I mean, I think that we need to be having these tough conversations more in our industry, and it's not and going into it with an open mind. I mean, there's no like winner and loser here other than our patients. So let's make sure that we're talking about the decisions we make being in the best interest of our patients. And I would just encourage, on the place we started with dogma, is that as clinicians, we're called to be scientists and to make sure we're consistently applying the science. And sometimes it can be really hard to think that you've maybe made the wrong decisions for patients in the past. And it's hard to challenge what we're doing today because we're accustomed to it. It's part of our clinical workflows, et cetera. But it's really important for us to be open-minded in adapting our clinical practices into best practices, which will continue to evolve because we're still, from an integrative and functional perspective, a relatively new field of practice. So thank you guys all so much for listening. And Mark and Dr. Holthouse, I really appreciate you both being with me today.
Honored. Thank you.
If you enjoyed this conversation and you want to hear more like it, I just want to remind you that we release a new podcast episode every Tuesday. You can follow us and subscribe at any of the places that you are streaming the podcast right now. And also just to remind you, we do have really great dialogue like this on all of the social media channels. So I encourage you to follow us at Dutch Test. I hope to see you with me next week.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.